Heribert Schunkert. He is the director of the cardiology department of the German Heart Center Munich. He's a professor of cardiology at the Technical University of Munich. He is known for his research in the molecular genetics of multifactorial cardiovascular diseases, author of more than 700 publications in international journals. He has coordinated several European and BMBF-sponsored projects, but what is most important of today, he is the scientific director of DigiMed Bayern, and he has put the basis, he constructed the project, which was then eventually financed by the Bavarian government, specifically the Bavarian Ministry of Health and Care. And now I would like to hand over to you. Thank you for joining us today. Thank you for making the introductory talk. Thank you for giving us the major keynote lecture today. The stage is yours.
Thank you so much. So welcome also from my side, and thank you for your kind words. I want to extend my special welcome to the Scientific Advisory Board of DigiMed Bayern, who was invited to participate in today's symposium, because I mean we have quite a bit of expertise here in Munich and Bavaria, but we very much welcome international expertise on our project, and as such we have several international advisors with us today. So my welcome goes to Vienna as well as to Maastricht, Würzburg, Berlin, Munich, and other places as well. So my topic for today is not that much a keynote lecture, but just a few words on the philosophy of DigiMed Bayern, which was initiated as a pilot project for preventive, predictive, personalized, and participatory medicine. Lots of P's in this words, in this sentence, and in this headline. And I want to bring you a little bit closer what we mean with all this. We, that is by now, after about 2 years, more or less a family of people and institutions that you see here that work together very well in Bavaria. Major universities are involved, but also Helmholtz and Max Planck. Likewise, the LAZ, that is the big IT hub here in Munich. There are also insurance companies, as you see, who support our project very much. And finally, there are patient organizations that are actually very much involved in the participatory part of our DigiMed project to bring forward instruments that are of immediate help for affected patients. And with affected, I mean basically those who suffer from atherosclerosis, because that is the medical focus of DigiMed Bayern. So what is the philosophy of our project? I want to contrast DigiMed Bayern with the Krankenhauszukunftsgesetz, which is a main project by the federal government, the health ministry, to improve the digital infrastructure of German hospitals. And they spend over the next 2 or 3 years a total of 4.3 billion euro to do that. Obviously a huge project which is very much welcome to improve the infrastructure, which is really in need in many German hospitals. There are several topics that are going to be sponsored by this law, which are mostly focusing on infrastructure, not that much on applications that are of immediate benefit for patients, and not that much on project that may improve the treatment in the near future. So this is actually what DigiMed Bayern is more about. We want to conduct case studies for digitized applications for improving the care of patients at risk for heart attacks and stroke. In doing this, in doing this, we basically plan for a handshake with the many opportunities that will come along with the digital infrastructure law of the Krankenhauszukunftsgesetz. So to bring you DigiMed Bayern a little closer, there are three important areas on which we focus our activities. The first is that we want to build improve the backbone for data safety, ethical and legal issues that are implicated with this 4P medicine that we want to improve. Just a small example in this respect. I want to show here that is a paper that is going to be published soon together with Theresa Feiler and Dr. Schlote. We had just a conceptual idea on how we could perhaps compare biobanks with libraries. And when we went through, there are many things very similar that may help to understand what the aims of biobanks are, and particularly when it comes to big data. I mean, what we want to do with this information, which is actually meant to improve many issues in the public as libraries want to do. Anyway, something, if you're interested in that, this paper is going to appear soon. Another important area is big data, proteomics. You will listen to Professor Mann later today, who is really global leader on wonderful applications to understand the proteomic landscape in human tissues or whatever kind of tissues, and not only tissues, but now in cells and organ structures and in healthy and diseased parts of the body. So with his help and his institution, we can now bring in big data into what we already have in outcome and other data on large numbers of patients who have been treated here in the German Heart Center and in the LMU when it comes to stroke patients. But when we actually started this, we were kind of naive when we wanted to build up this triangle between whatever kind of material that comes from a patient, which is something very private automatically, that then needs some sort of genotyping or proteomic typing, and as well as an infrastructure that can bring together the many clinical data as well as the big data that come from these omics platforms. Obviously there needs to be a lot of communication, that this communication needs to be well organized, and it needs to obey to the laws that we have in Europe and in this country. And we did this with the help of the Landesdatenschutzbeauftragten, the person who is in charge of organizing the data safety in our state. And we very much welcome his input, who actually taught us on the potential glitches in this triangle. So this is across many institutions, and that of course makes the communication from a legal point of view even more challenging. So, and finally, there are the clinical applications, which are the closest to my heart, obviously, on coronary artery disease and stroke. And I want to give you an example on how we perceive this P4 medicine of atherosclerosis. When it comes to myocardial infarction and stroke, we want to integrate all different kinds of layers of data, imaging, the laboratory data, the big data, and the long-term outcome into a single data warehouse, where we then try to understand patterns that basically depict the individual pathology, so that we can have, at the end of the day, individual rather than generic answers to the questions of our patients. And this actually is a scientific endeavor and led to quite a few publications. But I just want to show you one rather simple example that we came across over the last years. So some time ago, as part of this consortium, we identified a locus in the human genome that is highly significantly associated with the risk of coronary artery disease. Interestingly, we then realized that this allele that affects the risk of CAD has an implication for platelet function. So, as you know, aspirin is the globally most widely used drug in coronary artery disease. And then we asked the question, are there additive effects of our variant on one hand and aspirin on the other hand? And we did that in looking at a huge study in which, in this case, women and in another case, men were randomized to aspirin or placebo. And what you see here is that if a person carries the risk allele, then the chance of a myocardial infarction or a stroke were higher as compared to those people who were heterozygous for the risk allele, or actually carrying the non-risk allele. I mean, those people who are homozygous for the non-risk allele had the lowest risk, and that was to be expected actually from our previous publications. And then we looked at the effect of aspirin, and knowing that this variant has a poor effect on platelet function, it was interesting to see that those people who had the risk variant and took aspirin actually had a lower chance of an event by interfering with this mechanism. But then looking at the heterozygous and homozygous individuals, we saw that aspirin actually increased the risk. So here we have the situation. We now understand the genetic mechanism that affects platelet function. If the platelets are too sticky, and this is the case in this group, aspirin may be of benefit. But if the platelets are working perfectly, or perhaps being even less sticky than usual, then aspirin may be of harm. So all of a sudden, we can now individualize treatment that is meant to affect everybody who wants to lower the risk of coronary artery disease in primary prevention, I should say. So if a patient had a heart attack, then aspirin is indicated no matter what genotype one carries. So this was just one example where we wanted to involve big data in individualized treatment at the end of the day. There are other projects that you will hear about. One is about big data from health insurance companies. More than 1.3 million people with atherosclerosis in Bavaria have provided their data through their insurance companies, anonymized, of course. And here we are looking at individual outcomes across different groups of patients and different treatments of these disorders. Much more systematic approach comes from the Kooperative Gesundheitsforschung in der Region Augsburg, the CORA study, and the NACO study, the national cohort. Both are led by Annette Peters, who will speak to you tomorrow. Another project that is very close to my heart by now is the work on the prevention app and the risk calculator of the Deutsche Herzstiftung, which is a patient organization, very well perceived. More than 100,000 people are members of this organization, and the Deutsche Herzstiftung has several tools, and DigiMed Bayern is very proud to renovate quite a few of the tools of the Deutsche Herzstiftung, this risk calculator, and in addition to that, offer an interactive web platform that then can be out-launched by the Deutsche Herzstiftung as well as the Hochdruckliga with the support of the Techniker Krankenkasse to really improve the interactive patient care from a participatory view of these patient organizations. So you will hear more about this, I guess, tomorrow. Then one project you will hear about today, and this is already very close to the clinical practice is a screening that is throughout Bavaria for familial hypercholesterolemia, which is an inborn error of metabolism that leads to very high cholesterol levels, a very high risk of heart attacks. And unfortunately, there is no screening program up to now for this treatable disorder. And Dr. Zanin and I, we actually launched this project early this year, and by now more than 1,000 students from age 5 to 11 have already tested their cholesterol, and it will be 60,000 hopefully within the next 2 years. So a very successful launch of a big clinical study as part of DigiMed Bayern. And then I already come to an end. We are very glad that as very close collaborators and as a cornerstone really within DigiMed, we have these omics platforms at the Helmholtz Center in Munich and the Max Planck in Martinsried with, these globally highly respected researchers, as well as the IT concept and infrastructure from the LAZ that is headed by Professor Kranzelmüller. So, these institutions start now with the moderation, basically, of Professor Domdai, Dr. Wieler, and others. They start to communicate on clinical data, which is new to the field, but is urgently needed, really, if we want to move into a more modern and digitized medicine. We have to have these players talk to each other, and this on a legally respected infrastructure. And many of the DigiMed family did enormous pioneering work, really, to facilitate this communication. And all this has to be in the context of our society, so we are reflected by societal reflections and interactions, as well as guidance. And we have also legal advice, and Professor Gassner will talk to you right after the words from our Minister of Health here in Bavaria that will follow after my presentation. So with this, I just want to announce that DigiMed Bayern is led scientifically as well as by the management by these people here. You have heard already Professor Domdai, Dr. Wieler, and Dr. Sun. Very active and formed a great team with all the scientists across the many organizations. So with this, I want to come to an end. I see DigiMed Bayern as a digital challenge of P4 medicine: predictive, preventive, personalized, and participatory. There are predictive aspects, the multi-omics of CAD and strokes. We have to communicate digital disease risk and be preventive in doing that. We want to be personalized in perceiving the risks of individual patients, and participatory in that we support self-authorization by webs that will be launched under the guidance of DigiMed Bayern. So as you see, a quite diverse portfolio, but the philosophy behind is that we are seeking for digital instruments that are either sooner or later in the practical medicine, digitized medicine for improving the outcome of patients at risk for atherosclerosis, namely myocardial infarction and stroke. And with this overview, I want to thank you for your kind attention and hand over the word to Professor Domdai.
Thank you very much for your consumptive talk. I think you presented DigiMed Bayern in a perfect way. I think we now understand much better. Well, I would like to invite you for your questions, but maybe I start first. Well, I think I'm quite sure that, well, there's no comparable activity like this that you can find in Germany. Well, in maybe in other areas, maybe in the oncology areas, we see perhaps, yeah, somehow similar activities. But when you look at the field of cardiovascular diseases, have you identified in the past 2 years a similar project worldwide, or are we? Is DigiMed Bayern the only project in the entire world that is focusing in this way on the different aspects of digitalization of omics, and also bringing all in the other aspects that you talked about? Are we alone? Are we singles here, or how do you see that?
Well, you never walk alone, but I think I mean, one difference is that we are very application driven as compared to other institutions that are more technology driven. Let's say the Broad Institute, for example, or the Sanger Center are institutions that are, I mean, globally experts, globally leading experts on genomic applications or bioinformatic applications. Other institutions, they collect data from different sources, which is a wonderful thing that happened over the last years, that are big consortia that work together globally in feeding pipelines that were unthinkable really in recent years, where people bring together, let's say, genomic data from different ethnic groups to have really a global picture on the human genome in relation to disease. So all these activities are going on right now, but they're more technology driven, and our small project here is more application driven.
Mm-hmm. Okay. Well, I've seen one raised hand. Can you help this person that he or she can ask a question?
So, hi, do you hear me? Martin Paul here.
Hello, Martin.
Hey, yeah, no, thank you for your presentation. FYI, there is a similar activity in the Netherlands. Where else? It's called Health AI, and it has also the same application-driven focus with a lot of overlap. The only difference is not specifically focused against or for cardiovascular disease. It has a broader approach, but in terms of the methodology, the ethical aspects, how we bring databases together, it's very similar, and I'll be happy to make some contacts if that is needed. Of course, Maastricht is also, not of course, but Maastricht is also involved in this, so I'll be happy to connect.
Thank you very much.
Yeah, you want to comment that, please?
Well, I mean, obviously, I mean, the world is growing together, not only by Zoom and webinars, but I mean, we really can learn from each other. And in this respect, I mean, I'm involved in quite a few globally acting consortia. And I mean, if we can build bridges to the Netherlands, it wouldn't be the first, really, that would be helpful for both sides.
Okay, well, then there is one other question coming from Victor Solis, but obviously you have not switched on your microphone. If you do that, then you can start talking. If you still have this.
I think now you can hear me, right?
Yes.
Good. So yeah, Victor Solis from EPQMax here in the campus in Martinsried. I wanted to ask you regarding the preventative or the preventive app, the prevention app. What risk factors are you already including in this? Omics factors are already also in?
For the time being, we actually concentrated on established risk factors, because obviously we need validation of whatever we want to communicate to the patient. And it was actually quite an endeavor to take these mostly international scores and to validate these for the German population. Fortunately, we have CORA here in Munich, in Bavaria, and there's a similar project at the Baltic Sea. So we used local data to calibrate the most important international scores like the Framingham Risk Score, the SCORE project, and others to have a score that is calibrated for the Bavarian or German population.
I would like to take the chance to simply say that, I mean, here at EpiQMax, we focus on epigenetic factors, and indeed we have a submitted application also to add those factors into prevention apps or risk factor measurements. And I would also like to keep in contact with a consortium, indeed.
That would be Thank you.
Okay, there's one question in the chat. I'll try to read that. If you could perhaps elaborate a bit on the size of the data warehouse. I do not know if you can already say something about that, and is the matching and joint analysis working out?
Okay, this data warehouse basically integrates all data that have been stored in different places of the German Heart Center. So we are overlooking more than 100,000 individuals who have been treated in the German Heart Center over the last 20 years, and they are sitting in all different kinds of databases. Let's say the catheterization laboratory database, the lab data, then the follow-up data, then the data from the echo, for example, and of course we also have omics data on a few of these individuals. And the challenge was really to build an infrastructure where, I mean, these data could be integrated in a pseudonymized fashion into a single data warehouse. And this was something that has been done over the last years. So many interfaces have been created. And nowadays we are very happy that all these bits of information that I alluded to are now really being merged through all these many interfaces in this very heterogeneous data structure that we used to have into one data lake. So this is being done with the commitment of data safety that is needed for this nowadays. So we are overlooking basically hundreds of thousands of patients and all their clinical data that were collected over the years.
Wonderful. Thank you so much for answering also this question. I think we have to continue. Thank you for